Good afternoon, everybody. I'd like to welcome you all to our next session of the APDR National Virtual Noon Conference. My name is Dr. Hart Beatty. I am the chair of the Education Committee for the APDR and Neuroradiology Fellowship Director at Boston University. Welcome to our next session. Again, two really wonderful speakers and educators, and both happen to be program directors today. We're very grateful for their time. Before the introduction, we'll just go through a couple housekeeping items. As you know, the Virtual Noon Conference is always recorded and it is hosted on the YouTube channel for the APDR. You can search for that. In addition to the lectures being recorded, all the questions and comments are recorded as well. Your microphones are muted to ensure optimal quality. And if you do have questions for the presenters, we ask that you use the question and answer tool in the Zoom platform, and they'll try to get to the questions during the session, and if not, definitely answer them after the session. So I'd like to introduce our speakers for today, Dr. Asim Mian and Jamal Bokhari. Dr. Mian, Assistant Professor of Radiology at Boston University. We work together as colleagues in the Neuroradiology Division. He's also the Radiology Residency Program Director there. And Dr. Bokhari is at Yale University, Professor of Radiology and also the Residency Program Director. Dr. Mian will be speaking on emergency neuroradiology cases, and Dr. Bokhari on the terrible T's of testicular ultrasound. So we are so grateful for them. We know how busy everybody is now, especially with the new trainees and the start of the new academic year. But again, so grateful for your time for this project. So without further ado, I will stop sharing my screen and I'll invite Dr. Mian to share his presentation.
Okay, good afternoon, everyone. Thank you very much for joining this wonderful initiative that was one of Harp's brainchilds. I really appreciate Dr. Beatty's giving me the opportunity to talk today. So today, the topic will be emergency neuroradiology cases. You know, when you're at the workstation, doing your regular work day, you get a number of cases from the ER, or, you know, possibly from the floor, all sort of emergency type of cases. And just want to show you some of the cases that we see over here and some through my fellowship, and just how to approach them and some of the findings and what are some of the kind of follow-up studies that we should do. Just to introduce myself, as Dr. Beatty saying, I am the program director at Boston University. I'm also the director of fMRI. And please feel free, of course, to ask any kind of questions, and I'll do my best to answer them as I go along at the end of the talk. So the first case, these are the kind of histories we get, right? Not much. Trauma, pedestrian struck, which is actually pretty decent history considering some of the other histories we get. So as you can see over here, there is an intracranial hemorrhage. There's a subdural hemorrhage adjacent to the right frontal lobe, maybe a smaller subdural hemorrhage on the left as well. The other thing you can see is hyperdensity in the temporal parietal region. So you have a subdural hemorrhage and the subarachnoid hemorrhage, and some soft tissue swelling you can see externally. Now, the other thing, you know, in addition to these hemorrhages, we should always look at the bone windows, right? With all these hemorrhages, you must look for fractures. So one of the things you see over here is, you know, if you notice in the occipital calvarium, all right, you see the lambdoid suture, and it's asymmetrically widened on the left compared to the right. The right side, you really don't see much. It's as you would expect, not too wide, but on the left side, it is widened. So when you see that, you have to be concerned about a fracture through the lambdoid suture. Now, whenever you see a fracture in the occipital calvarium region or by any kind of vascular structures, you should always think about doing some kind of vascular imaging. Now, the lambdoid suture is right by the transverse sinus, and in this case, by the sigmoid sinus. So we always teach our residents, and we do this ourselves, we practice this ourselves. When you see a fracture in this location, anywhere along the occipital calvarium, think about a vascular injury, and you should most certainly order vascular imaging. And in this case, since by the transverse sinus, you should think about injuries to the transverse sinus. And over here on the non-contrast CT, you see this hyperdensity here in the sigmoid sinus, and this did project along the transverse sinus as well. You have a fracture over here through the lambdoid suture. You have a hyperdensity over here in the region of the sigmoid sinus. You know, the things that we're thinking about obviously is sinus thrombosis of the sigmoid and transverse sinus on the left related to this trauma. So we would order a CTV over here, and then on the CTV, you can see that there is a filling defect that starts from the jugular bulb, extends over here into the sigmoid sinus, and this is all related to this fracture over here. So there is sinus thrombosis of the sigmoid sinus, the transverse sinus, and the proximal jugular bulb, secondary to this fracture of the lambdoid suture. So the teaching point over here is when you see fractures in this location by vessels, you should think about vascular injuries, okay? Specifically, you know, especially over here, you think about injuries to the sigmoid sinus, transverse sinus, and think about venous thrombosis. All right, so fractures of the left lambdoid suture, jugular foramen, and left jugular vein thrombosis. Next case, this is a pretty, you know, common case we see. We always get this mental status changes. This is an elderly male, and, you know, because he had mental status changes, the images weren't great, but, you know, there was a lot of motion. Nonetheless, you can see there is a subtle increased flare hyperintensity of the medial temporal lobes bilaterally in this elderly male with mental status changes. T2 weighted images also shows this sort of subtle increased T2 hyperintensity of the medial temporal lobes as well. So, you know, one of the things you think about, obviously, in temporal lobe involvement, there are a couple things it could be. You know, you think about infarcts, but having bilateral infarcts in the medial temporal location is going to be very unusual. The other thing you should always think about is an infection, right? And in this case, medial temporal lobe involvement, you should think about herpes simplex, right? Now, in the post-contrast images, there was no contrast enhancement in this specific case. Diffusion-weighted images did demonstrate a diffusion abnormality of the medial temporal lobes, maybe some more diffusion abnormality of the lateral temporal lobe. Now, this is important. You didn't really see this here on the flare as much because I didn't show you the more higher up images, but there was some flare abnormality in the lateral temporal lobe in addition to the medial temporal lobe. So what you have over here is abnormal signal plus diffusion abnormality or restricted diffusion. In an elderly male with mental status changes, you should always, always, always think about herpes simplex encephalitis, okay? Because if this is not caught early, if you call this an infarct, this could potentially kill the patient, unfortunately. So if you have any concerns at all, please think about this and recommend this and tell your colleagues in the ER or wherever this patient is coming from, I'm concerned this patient could have herpes simplex encephalitis. Now, the reason why is because, first of all, herpes does not respect vascular territories, right? It'll be very unusual for you to have infarcts in the medial and lateral portions of the temporal lobes. These are two different vascular territories. Medial temporal lobe is the PCA, the lateral temporal lobe is the MCA, right? And in addition, you know, the other things you have to look for abnormalities in other areas that herpes can affect is the insular cortex, medial temporal lobes, all part of the limbic system, the anterior inferior frontal lobes, and the cingulate gyrus. So these are all areas that can be affected by herpes simplex encephalitis. So also pay careful attention to those areas as well to see if there's any involvement. And remember, herpes simplex, you can have diffusion abnormality or restricted diffusion, and that's not so much from ischemia, but it's from this excitotoxic effect of glutamate. It's beyond the scope of this lecture, but that's what is thought to cause the restricted diffusion. In addition, if it progresses on, you can have hemorrhages, you can have small microhemorrhages or even larger hemorrhages within the areas of abnormality. And again, it involves the limbic system, so the cingulate gyrus, insular cortex, medial temporal lobes, hypothalamic region, or mammillary bodies as well in some cases. So this is herpes simplex encephalitis. When you have abnormalities in medial temporal lobes, please think about this. And, you know, usually it's unilateral, but about 30% of the time it can be bilateral. All right, next case, another, you know, the typical sort of history that we get, mental status changes, right? Mental status changes. So on the flare, you can see flare signal abnormality of the basal ganglia structures, specifically the caudate and the putamen over here. You can also see some flare signal abnormality along the sort of the hypothalamic region over here. So again, flare signal abnormality over here, and also maybe some increased flare signal abnormality of the cortex of the temporal parietal lobes. So what are some of the possible diagnoses over here? So I have a couple of choices over here, right? Infarct, possibly, but you know, this is symmetric and specifically along the basal ganglia structures and also some involvement of the cortex over here. Metabolic abnormality, okay, fine, you could have flare signal abnormality, but you're typically not going to have diffusion abnormality, right, on with metabolic abnormality. Anoxic injury, sure, of course, right? I mean, this is a pretty typical setup for an anoxic injury, someone who's down, maybe drowning, or maybe because of a drug overdose. Carbon monoxide exposure, of course, this is another one that can cause this pattern of diffusion abnormality, restricted diffusion. Basal ganglia structures or deep gray matter structures, plus the cortex of the temporal and parietal lobes. So what are your choices? A, B, C, D, E, or F? All of the above. I think we sort of probably ruled out the infarct and the metabolic abnormality, or metabolic abnormality for sure, so that certainly excludes E. So I would say this is F, C, and D. So you could see this in anoxic injury and carbon monoxide exposure, right? So again, you have diffusion abnormality or restricted diffusion of the deep gray matter structures, plus the cortex of the bilateral temporal parietal lobes. You can see this again in anoxic injury from cardiac arrest, from drowning, from drug overdoses, and from carbon monoxide exposure as well. This is, again, a pretty typical pattern for anoxic injury from those different causes. Okay, next case. You have a young female who had mental status changes, and this is a non-contrast CT. All right, you see this hyperdensity over here in sort of the left parietal lobe region. And you know, some of the things you could think about is, first of all, what is this? Is this a hemorrhage? Sure, it could certainly be a hemorrhage. But one thing to note, why this would sort of not necessarily be a hemorrhage. If this were a hemorrhage, if this were truly a large hemorrhage or a hemorrhage of this size, you would see some surrounding edema. You really don't see that edema around here at all, right? You see very little, if any, edema at all. And then over here, I know it's sort of difficult to see, but notice this sort of linear hyperdense structure in the sulcus over here. So you have this sort of more globular area of hyperdensity, this more linear area of hyperdensity over here. And this young female who's potentially on, let's say, oral contraceptives, right? So first of all, what is the least likely cause of this finding? Vascular malformation? No, you can certainly have an appearance like this hyperdensity, potentially hemorrhage from the vascular malformation. Tumor? Yeah, tumors can be hyperdense. Sometimes they can hemorrhage. Migraine headaches? That'll be pretty unusual. Tumors, right? So the least likely cause for this would be, I would say, migraine headaches. Now, what is the next test? What is the next thing you would do? I would say you should probably do a vascular study, right? Like a CTA and potentially a CTV as well. If you have this sort of hyperdense lesion without a whole lot of surrounding edema, you're worried about some kind of vascular abnormality, potentially vascular malformation, or maybe some kind of clot or something. The next study you should do is a CTA and CTV. And on the CTA and in the venous phase, you can see that there is a filling defect in this sort of cortical vein over here, which became expanded because of the thrombus, and sort of the non-flow limiting or sort of not completely occlusive filling defect over here of this cortical vein, and the other hyperdensity that I showed you over here, that's also another cortical vein that has thrombus. This is cortical vein thrombosis, okay? And this, again, young female who's on oral contraceptives, perhaps a little dehydrated, you have this cortical venous thrombosis. So not necessarily along the major venous sinuses, but the cortical vein over here. So cortical vein thrombosis. So when you see something like this, a hyperdensity without a whole lot of edema, think about some kind of vascular malformation or potentially, venous thrombosis. And that's why you should definitely get vascular imaging such as a CTA or potentially a CTV as well. So cortical vein thrombosis in this young female. Okay, next case. This is a hemorrhage that you guys can see. So you have a hemorrhage, you have intraventricular hemorrhage, you have subarachnoid hemorrhage with the bilateral frontal lobes, here on the left, and you have quite a bit of hemorrhage along the interhemispheric fissure, right, anteriorly. Again, this next image shows hemorrhage of the bilateral frontal lobe, some hemorrhage along the interhemispheric fissure and septum pellucidum, and quite a bit of hemorrhage over here in the left lateral ventricle. So this is a non-traumatic hemorrhage. There is no history of trauma for this patient. Okay, so what are some of the things that you can think about? AVM, well, you don't potentially, but you don't really see some of those serpiginous, hyperdense structures that you potentially see with an AVM. Not to say you could not have a small AVM that ruptured, possibly. Basilar tip aneurysm, well, again, look at the pattern of the hemorrhage. That is a key point over here. Where is the majority of the hemorrhage? Where is it located? I'm not showing you the basilar cisterns because there really wasn't much hemorrhage over there, so that should give you a clue. ACOM hemorrhage, possibly, most certainly, most likely, right? Because of the pattern of the hemorrhage. MCA aneurysm, again, if this were an MC aneurysm, a ruptured MC aneurysm, I would show you the Sylvian fissure with quite a bit of hemorrhage in that location, plus a lot of subarachnoid hemorrhage in one of the other hemisphere. So here's the MRA, and you can see this little globular aneurysm arising from the anterior communicating artery right over here. Okay, this is an ACOM aneurysm, or anterior communicating artery aneurysm. Now, it's, again, as I was saying, it's very important to know the patterns of hemorrhage, which can sort of help you predict where the location of vascular abnormality is. Right now, with AVMs, obviously you have, typically those serpiginous, hyperdense vascular structures, and with larger ones, they're very easy to see. With smaller ones, it is more difficult. But regardless, you will get vascular imaging to see what's going on. Now, as far as, excuse me, some of the different patterns of hemorrhage. So here's an MCA aneurysm hemorrhage. You can see the majority of the hemorrhage over here is in the Sylvian fissure, in the temporal lobe, and interventricular extension, along with quite a bit of subarachnoid hemorrhage over here in the bowel cistern, right? So you see the majority of the hemorrhage is focused over here, or is located over here in the Sylvian fissure and temporal lobe, with a lot of subarachnoid extension into the bowel cisterns, supercellular cisterns, and frontal lobes as well. And again, extending along to the other side. So this would be a pretty typical appearance for an MCA and ruptured MCA aneurysm. Now, bowel tip aneurysm, you would see a lot more hemorrhage, again, in the interpeduncular cistern and bowel cisterns, some interventricular hemorrhage, but not as, you would see that more posteriorly. And of course, you would see more subarachnoid hemorrhage in a posterior distribution. Okay, so posterior distribution meaning along the occipital and posterior parietal lobes, and maybe the posterior temporal lobes as well. But this is a pretty typical appearance for a ruptured bowel aneurysm, bowel tip aneurysm, but again, hemorrhage in the interpeduncular cistern, that should clue you off or tip you off to potentially bowel tip aneurysm. And again, you see subarachnoid hemorrhage over here, and you will see some interventricular hemorrhage as well. I showed you the ACOM aneurysm, the ruptured ACOM aneurysm, and again, you see hemorrhage along the interhemispheric fissure, some subarachnoid hemorrhage in the frontal lobe and interventricular extension. And here's a PCOM aneurysm. That can be a little tricky. But again, notice where most of the hemorrhage is. There is some hemorrhage along the interhemispheric fissure, so that can get a little tricky trying to differentiate that from the ACOM aneurysm. But notice there's a ton of hemorrhage, a lot of hemorrhage over here in the bowel cisterns, which extend pretty symmetrically bilaterally. There's very little hemorrhage over the interhemispheric fissure. You should think about where most of this hemorrhage is centered. And again, think about a ruptured PCOM aneurysm. So again, hemorrhage in the Sylvian fissure and supercellular cisterns, right? So again, know your patterns of hemorrhages. With the pattern of the hemorrhage, if you can recognize a pattern, you can, more accurately localize where the potential offending vessel is. In this case, in the left Sylvian fissure, MCA aneurysm, the ones that I showed you down here, ACOM aneurysm, then interpeduncular cistern, bowel tip aneurysm, and again, most of it centered in the supercellular and bowel cistern, the PCOM aneurysm. Okay, here's another interesting case. We do have in our institution at BU, we have, quite a large, unfortunate immunocompromised population. So this is a patient who came in, actually this is my colleague's case, immunocompromised with mental status changes. You can see these sort of multiple flare hyperintense lesions scattered, or globular appearing lesions in the basal ganglia, frontal lobe, parasagittal right frontal lobe, maybe one over in the left occipital lobe, and a very large lesion over here in the left occipital and parietal temporal lobe, right? There's some mass effect, some partial effacement of the posterior horn of the left lateral ventricle, and over here, post-contrast images demonstrates a sort of peripheral enhancement of a centrally necrotic lesion. So again, think about a couple of different things. You think about tumors, such as lymphoma. Lymphomas, although they're usually more homogeneously enhancing in immunocompromised patients, they can be more heterogeneously enhancing. And you think about metastases from another primary tumor, and of course, you should always think about infection, right? So in an immunocompromised patient with mental status changes, now this is the autopsy result on that patient's brain. You can see a lot of these lesions are hemorrhagic. So again, hemorrhagic lesions in an immunocompromised patient, which also has sort of peripheral enhancement and central necrosis. What is the least likely diagnosis for immunocompromised patient with hemorrhagic lesions? So lymphoma, you can have lymphoma. Toxo, of course, in immunocompromised patients is one of the top things in the differential. Metabolic abnormalities, unlikely, right? Fungal infections, of course. Bacterial infections, of course. Any kind of infection or an immunocompromised patient is fair game, including lymphoma. So metabolic abnormality would be the least likely diagnosis in this patient. Now, what type of infection in the immunocompromised patient has hemorrhagic lesions? So toxoplasmosis, rarely, I've never seen a hemorrhagic lesion with toxoplasmosis TB. I mean, you can potentially have some microhemorrhages in that, but unlikely to have large, big hemorrhages like this. Bacterial abscesses, again, very unlikely. So this is going to be aspergillosis. Aspergillosis, you know, immunocompromised patients is one of the very deadly fungal infections that can happen. I believe it's the second or third most common fungal infection in immunocompromised patients. And when you see, you know, necrotic enhancing lesions with a lot of edema and they're hemorrhagic lesions, the biggest thing you should think about is aspergillosis. And again, you have to think about, you know, the patient population. Is the patient immunocompromised with these hemorrhagic lesions? You should always include fungal infections such as aspergillosis on the list, especially when they're hemorrhagic like this. Okay, next case. This is a young child who came in with fever, sore throat. And initially, when this was first read, you know, they're saying that ENT requested for drainage, right? So you have large, very large, prominent adenoids, right? So, and then on the post-contrast imaging, you see this sort of, you know, peripheral enhancement of a more centrally hyperdense lesion bilaterally in the adenoid tonsils. So initially, these were called abscesses, and ENT was requested for drainage. But before the drainage, ENT asked for the attending to look at this. And when the attending radiologist looked at this, you know, first of all, would you drain this, right? And the other thing I want you to notice is you have large adenoids and very large and prominent palatine tonsils as well. Would you drain this? This is a big, hearty no. Okay, you would certainly not drain this. And the reason why is because what is a differential abscess? Listen, yeah, it sort of looks like an abscess, but it's not. It's very bilateral, symmetric, involving the tonsils, very faint peripheral enhancement. So it's unlikely to be an abscess. Lymphoma, unlikely in this patient population, young patient. Bacterial infection, certainly it could be, but this is sort of symmetric, bilateral. There's no abscess. It's unlikely to be a bacterial infection. This is going to be a viral infection, and this is mononucleosis. A pretty typical appearance for mononucleosis, where you have massive enlargement of the adenoids, all the sort of the tonsils, the adenoid tonsils, the palatine tonsils, the lingual tonsils. The adenoids are massively enlarged, and don't confuse this for abscesses. These are symmetric, peripherally enhancing, hypodense lesions over here. Okay, so you know, these are just enlarged lymphomatous glands, enlarged enlarged adenoids with a lot of edema. This is just edema within the adenoid tonsils. So again, this is a do not touch, do not drain, and this is a viral infection, mononucleosis. If the patient's airway is compromised, you will have to think about getting, potentially intubating this patient if the airway gets too compromised. Obviously, there would be monitoring this patient, pulse ox, looking for stride and other signs of that. But you know, one of the other things that we should always comment on is the airway and how much narrowing there is of the airway. Okay, here's another case. We get quite a few of these. Our Boston Medical Center is the busiest level 1 trauma center in New England, so we tend to get quite a bit of trauma. And we see these at least, you know, multiple times a year. This particular case was a trauma MUC. And this patient had a CT because he had multiple fractures. You can see some of the fractures. I don't show you the bone minerals, but medial orbital wall fractures over here and other maxillofacial fractures. One thing, if you notice, is that there's prominence of the left superior ophthalmic vein. Okay, and in addition, look at the cavernous sinuses, right? There's asymmetric enhancement of the left cavernous sinus compared to the right. There's prominent asymmetric enhancement over here on the left compared to the right. You can see the right ICA, the cavernous sinus is, you know, fairly normal, maybe not enhancing as much, but over here you can see this very prominent asymmetric enhancement. This patient went on to, I'm sorry, the answer already popped up. This patient went on to have an angiogram, and there was a carotid cavernous fistula. So this is, again, a pretty typical history. You have a patient involved in a very high-speed trauma. You see prominence of the ophthalmic vein. You see asymmetric enhancement or asymmetric prominence of the cavernous sinus, ipsilateral to the abnormal ophthalmic vein. So in this case, you should think about a direct CC fistula or direct carotid cavernous fistula. All right, again, look for the asymmetry in the cavernous sinus for secondary signs like proptosis. of the orbit. You can get a history of, and you can actually hear the pulsation. If the ER physician chooses to do that exam, you can hear the pulsation. And again, look for that asymmetric prominence of the ophthalmic, superior ophthalmic vein in this patient. So pretty good setup for that. This patient went on to have a balloon embolization for sort of fix his carotid cavernous fissure. There are two kinds of CC fistulas, indirect and direct. Indirect ones are not related to trauma. They're usually associated in elderly females with hypertension. And that's more of an ECA to ICA sort of fistula. And this one is more sort of, as you can see, ICA to the cavernous sinus kind of thing. I'm sorry, ECA to cavernous sinus. So two different kinds of fistulas, and the etiology of these are both different. So this is some trauma. Okay, here's another typical case that we get, right periorbital soft tissue swelling in this young child who has sinus disease, I would say sinusitis, enhancement or pacification of the sinuses with some enhancement. You can see there's a lot of preseptal soft tissue swelling, remember, it's confined to the preseptal space. So when you have sort of concern for this infectious process, you want to describe it, you want to identify, is this infectious process or cellulitis, is it preseptal or postseptal? If it's preseptal, you can treat it more conservatively. If it's postseptal, those patients have to be monitored much more closely and potentially be admitted for IV antibiotics. So this is all preseptal inflammation. You can see it's not going into the postseptal space, which is posterior to the lacrimal gland. There's no inflammation or enhancement over here that you can see. This is right periorbital soft tissue swelling with a sort of an abscess over here. But then when you look at the coronal images over here, you might not see the postseptal involvement. Over here, you can see there is some postseptal involvement over here, right? This is both preseptal and postseptal cellulitis with an abscess over here in the right sort of lacrimal gland region. I'm sorry, I meant to put both preseptal and postseptal. But anyway, this is both preseptal and postseptal cellulitis with abscess formation, and this is secondary or sinusitis. So again, look for enhancement and inflammatory changes in the postseptal space as well, because if you have postseptal cellulitis, the edema can cause ischemic compromise of the optic nerve and ultimately blindness if it's not treated appropriately. So again, you can see some of the dirty fat over here in the postseptal space, which can cause compression of the optic nerve and eventually ischemic compromise. So again, always look for the postseptal involvement as well. Here's another case, drowsiness, acute mental status changes, and this patient was found down. You can see, I know my time is getting short, but you can see this abnormal flare signal hyperintensity and T2 signal hyperintensity of these structures over here by the third ventricle. This is the hypothalamic region, and specifically, what are these structures called? These are the mammillary bodies, right? So you have abnormal signal hyperintensity in the mammillary bodies, okay? And then you have restricted diffusion as well, all right, of the mammillary bodies. So you can see diffusion hyperintensity, ADC hypointensity. So what is the clinical setting for the MR findings? Abnormal signal hyperintensity and restricted diffusion of the mammillary body. So ischemia, acute infarct, that would be pretty unusual, right, to have this isolated infarct of the mammillary body. Heparin toxicity, that usually leads to more, you can either get a anoxic injury or sort of that chasing and dragging appearance. You get signal abnormality in the posterior distribution. Infection, no, not a typical appearance for infection. Alcoholism, certainly, most certainly, right? Carbon monoxide toxicity, that's also unusual. It usually doesn't affect the mammillary bodies like that. So this would be secondary to alcoholism. And what is the most likely diagnosis? Infarct, we already went through that. Unlikely to be infarct, not food poisoning. I just threw that in there just for the heck of it. Marquia-Fava Bignami disease, that is from red wine drinkers. That's usually you get necrosis of the corpus callosum and also involvement of cingulate gyre. So this is a pretty classic and typical case of Wernicke's encephalopathy, right? Where you get secondary to vitamin B12 deficiency, you get involvement of the mammillary bodies, you get atrophy and high signal, maybe some enhancement of the mammillary bodies, right? In addition, you get atrophy of other brain regions as well. So Wernicke's encephalopathy. So all the following are findings in Wernicke's encephalopathy with ETOH except hyperintensity of the mammillary bodies. That's true. Hyperintensity of the hypothalamus, certainly true. Hyperintensity of the medial thalami and periaqueductal gray matter, right? So these are all findings in Wernicke's encephalopathy. How about the bilateral hemorrhagic cutaneous necrosis? That is not true. That is the one that is untrue. And the reason why is because that is not seen with ethanol toxicity, but that is seen with methanol toxicity. Some people, these unfortunate souls who drink rubbing alcohol, right? That is extremely, extremely toxic, and you can get, what happens, you get hemorrhagic cutaneous necrosis. So you get necrosis, ischemia, necrosis of the putamen of the basal ganglia with hemorrhagic transformation. That is seen with methanol toxicity. With ETOH, that is more Wernicke's encephalopathy, and these are the findings that I'm talking about over here: the mammillary body abnormality, hyperintensity of the hypothalamus, and hyperintensity of the dorsomedial thalami and the periaqueductal gray matter. These are all pretty typical appearances of Wernicke's encephalopathy. So I'm just going to go quickly now, since my time is nearly up. You have mental status changes. You have abnormal signal abnormality, clear hyperintensity of the corpus callosum, both the genu, the body, and the splenium. You have enhancement of the same regions of abnormality, and it's crossing midline, right? So you have an enhancing lesion that is crossing midline. There are only two kinds of things that can do that, either GBMs or lymphomas. Okay, so what is a likely diagnosis? I mean, it does show diffusion hyperintensity. This is going to be a tumor, right? So this is going to be either a GBM or lymphoma. Infarcts, potentially, but you have this sort of solid enhancement. Abscesses are not going to typically cross midline like that. Epidermoid cyst. This is more solid, and it's not cystic as you would see with epidermoid cyst. So this is going to be a tumor. And again, we already spoke about what kind of lesions can cross midline. So gliomas and lymphomas A and C. The last case, this is an MBA. Again, we see this quite frequently, unfortunately. This is an MBA, young patient, a high-speed MBA, and he had neck pain, he had some paresthesias and numbness. So if you look carefully along the cervical spine, you should look for the facets, and they should look like shingles on a roof, right? So this is lined up nicely over here, 2, 3, 4, 5, 6, 7, and then at C7T1, you notice that this, sorry, 60 at C7, you notice this is first, and then C7T1, this is sort of more posterior. So again, you look at this again. Here's C7T1, right? So this facet is abnormally located with respect to the facet below it. So you have a locked facet, right? Notice these facets over here nicely positioned. This normal appearance, which is shingles on a roof, but over here, this facet has been dislocated, and this is called a locked facet because of this high-speed MBA. All right, and again, you can see that over here as well as you scroll through this locked facet of C7T1. This facet should be located sort of posterior to the superior facet. The inferior facet of C7 should be located posterior to the superior facet of T1. So what type of cervical spine injury is this? I already spoke about this just for the sake of time. Clay-Shugler's fracture, no, that's fracture of the spinous process. Hangman's fracture, that's fracture of the posterior elements of C2. Milkman's fracture, I completely made that up. It's not even a real fracture. And then over here, you have locked facet fracture dislocation. So this is deep. Right, this patient went on to, again, have a fusion, and they're trying to reduce that. But, again, a very, very devastating injury. Usually these patients don't do well. They, unfortunately, I can either have paraplegia or quadriplegia, depending on what's happening. So, locked facet. Well, thank you very much. Again, thanks a lot for joining. I appreciate your time. I will now review any kind of questions you have. If you guys have any other questions, or if you want to reach out, this is my email. Again, thanks a lot, and thank you to Dr. Beatty again for allowing me to do this. Thank you.
Thank you so much, Dr. Mian. Really beautiful cases and important ones for all level of residents to familiarize themselves with. I'll ask you to stop sharing your screen and invite Dr. Bokhari to begin his presentation. Please, Dr. Bokhari.
Okay, thank you very much, Harp. So I'd like to actually start by thanking Dr. Beatty for setting up such wonderful sessions during hard times. Very educational, great initiative. Also, I really enjoyed the cases that Dr. Mia was sharing. And again, thank you for inviting me for this presentation. So what we are going to discuss today is really a pictorial of problem solving for testicular ultrasound as cases come into the ER. And they're discussing what the overlaps are of various pathologies and the mechanism for ameliorating these problems. So what I really want you to focus on this slide is just one thing, and that is the anatomy, that the ductus deferens or vas deferens enters the epididymis at its tail, not the head. It enters the tail and then goes up into the head and through that into the testicle, or the other way around if you follow spermatic flow, but that anatomy is critical. So what are we going to discuss? We are going to discuss infections, torsions, trauma as the main course for the day. And then if we have time, I will touch upon the other entities too. So starting with the infections, epididymoarchitis, we are all familiar with. So epididymoarchitis, for the etiology can be divided up into the adult and pediatric population. In the adult population, the sexually active population, vast majority of those get sexually transmitted disease, and the non-sexually active or the older population gets coliform bacteria. There are rarer forms of adult epididymoarchitis, including candidal infection in immunocompromised and tuberculosis in the tuberculous endemic areas. Sterile inflammation can be seen with immunotherapy therapy or radiation therapy, prostate brachytherapy specifically. Now, the pediatric epididymoarchitis can be subclassified in two ways. One is whether it's isolated epididymitis or whether it's orchitis or epididymoarchitis, where the testes are involved too. So the isolated epididymitis often are due to the infection coming in through the vas deferens and the ductus deferens. And in the early neonate, this may be chemical from reflux of sterile urine or maybe post-infectious with enterovirus or adenovirus. Epididymoarchitis or architis is mostly viral infection. The other way to look at it is whether the age of the patient, whether it's neonatal or prepubertal. Now, neonatal is going to be mostly chemical epididymitis due to reflux of sterile urine, in which case you have to look for associated congenital abnormalities that allows for this. And in prepubertal, it's mostly, again, viruses and infections. Now, post-pubertal, the overlap with sexually transmitted diseases and adult type infection inflammations becomes pretty significant. So enough with word slides, let's look at some images. Now, this is your typical presentation of that the ultrasound tech gives you for most part when they are showing you epididymis. It is often just one or two pictures of the epididymal head with measurements. And that is pretty standard across the country, but this is totally inadequate. Because of the anatomy that I've shown you, most of these infections being coming down or up the ductus deferens, the tail of the epididymis is going to be involved first. So you should always look at the tail, as in this case, this was actually epididymitis, which would have been missed if the tail had not been imaged because the head looks totally normal. Here's another case where really slightly heterogeneous head, but not really hyperemic, not much to say on this epididymis. But if you look at the tail in this case, the tail really lights up. So this is another case of epididymitis or tail epididymitis, which was affected before the head and the testicle will be affected. So the tail of the epididymis, rather the whole of the epididymis, must be imaged. And I always ask the technologist to show me an image like this, which is a laid out image of the epididymis so that I know where they are looking for, because as you know, the images presented, you can't even know whether they are looking at the tail or they're looking at the head. So this is a critical image that you must ask for in all testicular cases. Epididymis is the key to testicular ultrasound. What are some of the complications and sequelae of epididymoarchitis? For interest's sake, you can get unloculated or complex hydroceles with severe epididymoarchitis. You can get testicular abscesses. Those testicular abscesses can rupture the tunica and become scrotal abscesses. And in those cases, you will see the classic stud or the collar button or collar appearance of it. Keep this image in mind. You will see it later in other pathologies, hence the overlap. And here's another example of ruptured testicle due to abscesses or severe infection. You can pay attention when you get echogenic foci. Is it calcification? Is it air? In this case, it's air. And you don't want to miss this finding, which is a testicular abscess with Fournier's gangrene. And you will have the opportunity, you may have the only opportunity to make that finding when you're doing the testicular ultrasound, unless the clinical staff is thinking about it. Now, as a sequela of all of this, you can get a shrunken heterogeneous cystic testicle, and the patient may still present with acute pain or acute on chronic pain. And this is a sequela of chronic infection. It can be a sequela of chronic trauma also. And this actually is an example of orchialgia or orchidynia, chronic pain syndrome that you can see post-infections. It's a shrunken, small-looking testicle, and the similar appearance you can see, as you will see later, in post-surgical testicles too. So there's a lot of overlap in these cases. And in this particular case, the reason for chronic repeated bouts of infection were obvious. The patient has had spinal surgery and had paralysis and a neurogenic bladder with repeated infections. Okay, so as you are extending that ultrasound scope, remember that the infections actually travel down, and they're traveling down the spermatic cord. So always also have your technologist give you an image of the inguinal canal or the spermatic cord, and that will become important as we go on. And here in this particular case, the patient actually has a spermatic chorditis, and you may see that in isolation before it extends to the epididymis or the testicle, and the pain will be referred down to the testicle, and they will come with testicular scrotal pain. You don't want to miss this finding also, because it gives a reasonable explanation of why this patient is having pain. Let's switch gears and talk about torsion over here. So this is a classically torsion with enlargement, heterogeneity, and lack of flow. But in addition to that, always pay attention to the epididymis with torsion, or whenever the pain is, if somebody comes with pain. In this particular case, as you can see, that the epididymis was enlarged and heterogeneous. So let's just look at some of the findings we talked about. One was the echo texture. Now, texture comes abnormal. That means you have to familiarize yourself with what the normal echo texture of a testicle is. And that can be a little tricky. The striated testicle of echo texture, which is heterogeneous, and at first pass, like me, the abnormal testicle can be a normal finding. And in this particular case, it is a homogeneous texture, which is abnormal. So always have the comparison view of the testicle. Another important thing that you have to ask the technologist for, in case it's not given. Another telltale sign in this particular case is, if you look at the size measurements, this is the larger testicle. In an acute setting, it's invariably going to be the more abnormal testicle is going to be the larger, and the testicle has lost its normal heterogeneity and become homogeneous, and that's the abnormality, as is confirmed on the comparison color images, where there is color in the left testicle but not in the right testicle. Further, there's no flow there, so this is testicular torsion. If you look at the epididymis, as you always must, you will see that the epididymis is enlarged and somewhat swirled over there. Here's another case. Is it always the case that there's heterogeneity and the size is large? Let's look at this case. For most part, the testicles are sort of equal in size and volume, and one testicle is not that different in echo texture from the other testicle. Here's a comparison shot. Now, looking at that, they both look rather symmetrical. Symmetry, as we've been taught, is a sign of normalcy, but you have to look closer when there is pain. And here, when you put color on the testicles, you will realize that one testicle has no color, the other has color. So how do you distinguish this? What's going on over here? Well, look at the key to the ultrasound, which is the epididymis, and the epididymis is abnormal on the right side. And so what is going on here? I will get to that in a moment. The key thing over here is that the size may be comparable, echotexture may be comparable, flow is very important, but even that may be normal or hyperemic in the case of an intermittent or partial torsion, especially intermittent torsion. The epididymis is going to be the key. So pay attention to the epididymis. As you have seen in this particular case, it's heterogeneous and it is enlarged. Here's a case where the testicle is very, very heterogeneous and it has some flow, but no diastolic flow, so very poor flow. And if you compare with the other side, which I haven't shown you, the other testicle was rather homogeneous and had good flow. The patient had history of repeated episodes of pain over many, many months and was coming in again with such episode. And this was chronic intermittent torsion with sacula, as you have seen. And in this particular case, if you look at the epididymis is again noted to be abnormally enlarged. So here's a case where you have good flow to the testicle. The epididymal head is slightly heterogeneous, maybe a little enlarged. As you can see, there's flow in it. It is definitely hyperemic, especially as compared to the other side. And when you look further in the epididymis, you will see this swirling pattern. That's why it is very important to see the entire epididymis. What I ask the technologist to do on every case is to give me one cine loop, if they don't know what they're looking for, one cine loop in axial dimension from the epididymal head across the tail to the inguinal canal, mouth of the inguinal canal, the internal ring. And that will then help you see the epididymis and see the cord itself. So this patient actually had partial torsion. You still have good flow. The epididymis is the key, which will help you make this diagnosis. As you can see, a little hyperemic, but you have to then look up into the cord to see the abnormality over here. So here's what it will look like on a cine loop, where even if the technologist doesn't know how to do it, if you see the cine loop with the torsion, as you can see, more than 360 degrees in this case, you have a diagnosis of intermittent torsion. It will have good flow and maybe normal echotexture. You don't want to miss this because the patient can be sent home and they will come back with a dead testicle. Okay, so more cases just to help with that. Again, a very you have normal flow, very abnormal epididymitis, very abnormal epididymis with hyperemia. So why is it that the epididymis is always abnormal in testicular torsion, and is there an exception to that? And the answer is it is abnormal because the torsion invariably occurs in the portion of the cord which is right next to the epididymal head. That is the area that torses. Now, the one caveat over here is that redundant spermatocord is always redundant and tortuous. Do not get fooled for a spiraling of the spermatocord with that. So remember the difference between a twizzle stick, which is a very long spiral, and a bow tie, which is a very tight spiral. In torsions, intermittent torsions, it's going to be a tight spiral near the epididymal head. That's why the epididymis is the first structure to get affected due to venous congestion and then becomes engorged. And that's why it's going to be abnormal. There's one rare exception to it, which is called gubernacular torsion, which is due to a congenital abnormality where the torsion occurs between the epididymis and the testicle, but it is so rare that we are not gonna spend more time on that. So the epididymis can be a red herring or a red flag. Pay attention to discordant information. Okay. So how do you then tell the intermittent torsion versus epididymitis? Because intermittent torsion will cause hyperemia. Both will have abnormal epididymi, and that becomes a problem. Well, one is evaluate the cord. If you see twisting in the cord, then it is likely intermittent torsion, and you have to pay attention to that. But pay attention to discrepant findings also. With epididymitis, the testicle may be normal if there's no orchitis. But with intermittent torsion, the testicle is not going to be normal, or going to be normal less likely. So pay attention to testicle, pay attention to history, signs, and symptoms. Look at the position of the testicle. Watch out for Pren sign, which is a relief of pain with elevation of the testicle that you can get with epididymitis, but not with torsion. Have a high index for suspicion based on the symptoms. You can always ask for markers for inflammation that you will get with epididymoarchitis, such as C-reactive protein and sedimentation rate. And the C-reactive protein, if it is negative, then it's less likely to be epididymoarchitis, and you really have to start worrying about torsion in that particular case. Okay, let's move on from there. This is actually I just wanted to show you, we talk about bell clapper's deformity all the time. You've hardly ever seen it, because most of the time the bell clapper's deformity is it's a potentially visible deformity. It's not really visible on ultrasound or CT, because the bell is essentially collapsed around the clapper, so to speak. But when you do have a hydrocele, then it can become evident in those people who have it, because the fluid separates out the bell from the clapper. So we talk about it all the time, but not a deformity that is often recognized by ultrasound. Okay, now remember the shrunken, deformed testicle that I showed you. You can also see that as a sequela of torsion, and that is not directly a sequela of torsion as much, although the testicle can infarct and become small in torsion, but much more commonly in a pexied testicle. So the treatment for this is orchidopexy, and when you do that, the testicle is pexied to the side wall and looks like a smaller shrunken or a bean-shaped testicle. So there's overlap over there. I just put this in for completion. You will get torsion of the appendix epididymis, or the appendage, or the appendix testes. Both are different structures embryologically. One is of Wolffian ductal region, the other is Mullerian ductal region. That's just for extra points in somebody's trying to pimp you on these questions. Otherwise, really no significant in terms of their management. And again, remember that even these structures can have intermittent torsion and can be hyperemic or can be inflamed also. There are certain variants to it. This is a case where this very large structure, as big as the testicle, has no flow in it, and it was first thought to be a testicular torsion, but then another testicle was found. So the confusion was, does the patient have 3 testicles when one it is tossed? But if you pay attention to it, you will notice that there is actually a twisting right there. It is a very large testicular appendage that has torn in this patient. So the appendages can be large. That's the point over here. Okay, now you can get infarcts of the testicles independent of torsion with entities such as sickle cell. So keep the history in mind. If you have areas or poor flow in the testicle with chronic infarct, you may get poor flow or just peripheral flow. Well, let's get to trauma, and that's the interesting part of the talk, more in terms of the history as well as the images. So here are some interesting cases which hopefully are not a general reflection on the population of New Haven, but these are cases from New Haven. So this person actually shot himself in the scrotum willfully as a part of an initiating ceremony to a street gang. The key thing when you have scrotal trauma to look for is what you're looking for is obviously hematoma, hemorrhages, but whether the tunica has been interrupted or not. That is what's going to lead to surgery or not. Is there tunical disruption or not? Just like in case of Fournier's gangrene, the overlap here is that there is air in the scrotum, and if you pay attention, there is air under the tunica. So clearly the tunica in this case has been disrupted, although it may have been disrupted by the blast effect. Obviously, this guy went shy right in the end and probably didn't aim totally for his testicles. But he did get blast effect and ruptured his tunica and had to be repaired. And further to the blast effect, you'll see an area of hyperemia, and that's another point. With trauma, you can get hyperemia of the testicle and the epididymis, and it can look like orchitis or epididymitis. Here is another case, as you can see, with tunical rupture and air in the testicle itself, demonstrating that there has been disruption of the tunica. And here, like I showed you the collar sign of tunical disruption with the abscess, you see the same collar sign or the stud sign, collar stud sign with the disruption of the tunica, but this was due to trauma. Now, in this particular case, again, you see the same signs, the history, and I'm not going to repeat them again, but this tunical disruption. The history was that this was a fireman injured while fixing a hose. How did that happen? Well, this guy had the hose between his legs pointing at his scrotum, and his colleagues in the firehouse thought it would be a great idea to pull a practical joke on him and turn on the fire hose, which they did. The pressure on these hoses is immense, and as you know, they are also used for crowd disruption. And to push that, actually he had a testicular disruption due to the pressure of the water from the fire hose. Okay, so here is another case, and this kid was hit in the scrotum with a rope. Another interesting history, and if you look further, dig further into the history was that his brother and him decided, they were asked to cut a tree by the father, so they cut the tree, dropped it, and then and they had to haul it to wherever they were going to pile the wood. But instead of cutting it and chopping it up site, they decided to haul the whole tree up on their pickup truck, tied a rope to it. The younger brother was sitting astride on the back of the truck while they were pulling the tree. The rope snapped, and when these ropes snapped, like whip, you all know, the cracking sound of a whip, and the whip cracks is because the tip of the whip breaks the sound barrier. It is traveling so fast. This thing then snapped him in the testicle, and he got a testicular disruption. Another case of mild dull pain and swelling for 2 months, and this is in an alcoholic who had no idea what had happened to him. We didn't know whether this was an abscess or a hematoma. Got an MR for problem solving, turned out it was just a hematoma. On further asking him, he apparently was kicked in the groin in a bar brawl 2 months back. So this is a chronic hematoma that may come in the problem solving, is that you will get an MR on these particular cases. Last interesting case of trauma is that the hemorrhage may just involve the scrotum, not the testicle itself. So you have to pay attention to that, but it can have mass effect. It can compromise the flow in the testicle, and therefore scrotal hematomas, although they're very capacious, do have to be decompressed if they're causing flow compromise in the testicle. The story on this guy was that this guy was riding a mechanical bull that had been put in a bar in New Haven, and was obviously drunk and was being egged on by a bunch of people. So he overrode the bull, so to speak. And here's the CT showing the scrotal hematoma. Reminds you of Einstein. Why does it remind you of Einstein? Okay, so there are other etiologies, and I'm running out of time, so I will not show you, but go in detail. But the whole idea in the next few cases, you will see that in this particular case, when you have trauma, it can really look like inflammation. As in this case, it looks like epididymitis. So getting the history is very important. Also, to further confound the problems, when you get epididymitis, they often present as if they've had some minor trauma. The epididymitis declares itself that, oh, I bumped against the table, or I was bicycling. That's because that's when you feel the pain and come in thinking that it was related to trauma, but the history. So getting the exact history may be important, but can be problematic. And remember that the injury may not just be to the scrotum or the testicle. When you're doing an ultrasound, also look at other areas. And this was a straddle injury under the penis, giving a hematoma and causing mass effect on there. Post-traumatic, you can get calcifications. Okay, so I think the time is up, so I'm gonna skip through some of the other cases like the tumors and the transmitted pain and all that stuff, and go to the crux of the matter as to what you have learned and what you want to do. So the summary is, the signs and symptoms can be non-specific. Ultrasound can have overlap findings between infection and torsion, trauma and infection, tumor and trauma, which I was not able to show you, and hernia and torsion also. So how do you solve these problems? Well, you have to be thinking all the time on your feet when you're doing testicular ultrasound. Don't take them casually. It is absolutely necessary that the ultrasound technologists give you complete images of otherwise you have to go scan yourself. Scan beyond the obvious, evaluate the entire epididymis, cord, inguinal region, and even the abdomen. If there's a hernia, you can tell whether there's a cystic mass or a hernia. Well, look for the bowel. If there's dilated hyperperistaltic bowel, you're sitting on an obstruction and a hernia. And I can't tell you how many times hydroceles have been called, which are actually distended bowel, which are incarcerated and or strangulated in the inguinal canal. So look at the abdomen in those cases, especially in pediatric population, and make sure that there's no obstruction that you are missing. Check all studies, other studies meaning CT scans, MR scans that have happened, correlate with labs. If all else fails, make sure that you have a high suspicion, make it very clear to the patient yourself and the clinicians that if the symptoms worsen, they have to come back, in a very short duration. Consider doing an MR, and be very, very clear in your reporting. If you think that the signs and symptoms are non-specific or vague, do not use vague language to reflect that. Be very clear of your uncertainty that, look, we cannot tell because of the overlap, and this is what we need to do to follow the patient up. That was my scrotal pearl. Thank you very much. Hope you enjoyed the conference and learned something from it.
Thank you, Dr. Bokhari. I really appreciate it. In fact, I was thinking about joining a street gang, but have decided against it now after seeing your case. So it's a life lesson. Again, thank you for your time and your dedication. And I thank the attendees. We will see you again next week for week 15. And have a great weekend and be well.